Initial trauma and injury cascade. Non-penetrating traumatic brain injury, or TBI, occurs when a severe impact causes the brain to crash into the hard bones of the skull. Rapid acceleration and deceleration of the brain creates shearing forces that tear open blood vessels and damage brain structures. As a result of the impact, local disruptions in the vasculature can cause some areas of the brain to become ischemic if the supply of circulating blood is reduced. As the damaged tissues expand in volume during inflammation, the effects of widespread swelling within the brain case creates pressure that further restricts blood flow and increases damage. This intracranial pressure, or ICP, occurs in approximately 40% of all patients with severe TBIs. Rising ICP following injury can be an indication of cerebral hemorrhage. When the pressure in the skull rises too high, this can cause herniation, in which soft areas of the brain are squeezed by rigid structures in the skull. Brain death often occurs if ICP cannot be reduced and brain hemorrhaging stopped. Patients presenting with acute TBI are stabilized as quickly as possible to prevent further injury. Primary treatment concerns are proper oxygen supply, adequate cerebral blood flow, and controlling intracranial pressure. Emergency surgery can be performed to remove clotted blood, hematomas, repair skull fractures. Supportive measures to keep cerebral perfusion optimal and reduce intracranial pressure, if increased, include sedation, fentanyl, midazolam, propofol, paralysis, pancuronium bromide, ventricular drainage, removal of liquor through ICP catheter, mannitol or hypertonic saline, pressor agents, dopamine, hypothermia, hyperventilation, barbiturates, and as a last measure, decompressive craniectomy. Many TBI patients deteriorate after hospitalization and initial treatment despite stabilization. This is caused by secondary injuries, a complex set of cellular and biochemical cascades that can occur within the first minutes and even days or weeks after the initial TBI. These secondary effects can make the initial trauma worse and are a major factor in fatalities from brain injuries. In the brain, the damaged neuronal tissue reacts by secreting a hormone signal called VEGF. At the synapses, normal communication between cells is overwhelmed by excessive secretion of the glutamate neurotransmitter. The flood of glutamate opens receptors on the postsynaptic cell, causing extracellular calcium to rush into the cytoplasm. While this is happening, the membranes of the cell's oxygen-stressed mitochondria are beginning to rupture. The broken mitochondria release cytotoxic factors and another flood of calcium ions into the cytoplasm. The combined effects of high intracellular calcium and cytotoxic factors are strong enough to cause some neurons to undergo apoptosis. These dying neurons may not be replaced, resulting in permanent brain damage. In those parts of the brain that are closest to damaged vasculature, the breakdown of the blood-brain barrier allows blood-borne inflammatory components free entry into spaces that normally restrict this kind of invasion into the brain. Macrophages from the blood that are activated by the injury will secrete inflammatory molecules that cause further stress to brain cells, including glia, neurons, and their myelin sheaths. This cascade of responses to traumatic brain injury often occurs in multiple areas across the brain, and the damaging conditions can persist and even increase in severity in the days after the initial damage.